We're also recording the movie, or the movie. It's a movie. We're also recording the meeting today. So just so everybody's aware of that. We have a few members of our quality improvement team. So we have Amanda and Christine with us. And Mariska, of course, is our guest speaker. So we'll do a little introduction later. So I think we'll get moving with our land acknowledgement. We acknowledge that the Westview PCN sits on Treaty 6 territory and express gratitude and respect for the land that we use. We pledge that we will actively work to end systemic racism, continue to participate in truth and reconciliation, and partner with our neighboring First Nations to improve programming, services, and resources in our community. The Indigenous people's spiritual and practical relationships to the land create a rich heritage in our learning and our life as a community. So today's meeting, as everybody knows, we have a bit of an agenda. So the first thing on our agenda is we're going to have a little bit of a shadow billing update. So we've been changing the processes a bit with that. We've had some meetings and some good conversations about this. So we're going to have Amanda give that update in a minute here. We're also going to have our guest presentation from Mariska and then a few updates at the end of the meeting. So first off, I'd like to introduce Amanda Boma. Everybody knows her, of course, so she's going to give us a little update on what's happening on the board goal to evaluate our shadow billing and clinical associate program.
Hi, thank you, Christina. So first and foremost, we appreciate your receptiveness with how well things are going. I know it's not a brand new process, but what I have seen so far looks really good, and I really appreciate everybody's efforts in doing this. We did have a working group with the CAs last week that met to discuss about how things are going, where I'm at with the data, and what you would like to see back when, at the end of January, hopefully when everything is all good to go. So each step with this shadow billing is up for discussion. So if there's anything that's like a pebble in your shoe, you're more than welcome to reach out to me or anyone on my team, and we can look into whatever is going on and discuss it as a team. So thank you for all of you who have reached out with any questions or concerns or basic questions, complex questions, situations. It's all been really good feedback to have. I also want to mention that 780 is not a good code to use as a diagnostic code. So if we can make sure that we're looking at the reason, the background of the patient and why they're coming for a visit, that would be really great. So we have, and then, I also wanted to mention that we understand that different clinical associates have different role, like some have multiple roles in a clinic. So if you've been documented to the PCN that you're a 0.2 FTE for an LPN, then the shadow billing that we would receive from you should reflect that. We know it's not going to be 100%, but it kind of gives a good idea of what you're doing as an LPN within your role for an example. So if you have any questions about that, absolutely let me know, and we can have that. You can ask your clinic managers if you don't know exactly what that looks like for you, if you have multiple different hats in your role. But yeah, your shadow billing, if you're working only at 0.2, which is like a 1 day a week as an LPN, sort of the equivalent. Of course, if you're wearing multiple hats, it's dusted in there in your daily goal or in your daily routines. But yeah, just do your best and send whatever you're doing over to me, and I will make sense of that data. But if you have any questions, definitely let me know. Other than that, we are putting some visuals together finally for the data. And so once we have that, then we can break it into smaller pieces as for each clinic and each CA specifically, and then we can get you that information back. I am super excited. So each step of the way, if you have any feedback for us, just keep sending it through. Any questions or anything right now? All right. Well, sounds good. I'll give it back to you, Christina.
Thanks, Amanda. Again, like Amanda said, if you have any questions, you can put those in the chat throughout the meeting at all, or you can reach out to either one of us about shadow billing or anything else that might pop up. All right, moving on. Technology's fun. There we go. Look at that beautiful face. All right, so it is my greatest pleasure to introduce to all of you guys one of our staff members, Mariska Gordon. So Mariska is a registered dietitian, and she works with our nutrition services and in our obesity clinic at the Westview PCN. She is a wealth of information because not only is she a dietitian, she's a certified diabetes educator and a certified bariatric educator. So these, certifications aren't easy to get or to keep, is what I keep hearing. So we're weighing heavily on her information and her skills so that she can help us to learn more about how to manage some of our patients with diabetes and chronic diseases. So the goal, hopefully, for today is for Mariska to give us a few tips on how to manage our patients while they may be on a waiting list to see her, things that we can kind of help to fill in the gaps for her and make everybody's life a little bit easier. So with that, I will give it away to you, Mariska. Thank you so much for joining us today.
Well, thank you so much for the very gracious introduction. And it's lovely to be with you all on this super snowy day. I'm just going to get technology to listen to me for a second and get my slides going here. And just double checking that everyone can see those okay. Thumbs up, hand. Oh, love it. Thanks so much. So, yes, I just put together some slides today, but in no means do I mean to spend a ton of time on every slide. The set of slides is more so designed as a package of resources, information, and clickable links. And I will make sure to pop a copy of all the slides with the clickable links as a PDF in the chat as soon as I'm done presenting. So you can all have a copy to look back to and reference. Now, when you think of your patients that you see in your practice when it comes to pre-diabetes, diabetes, is there anything really specific that comes up all the time that you would like more information around, or a resource that you wish you had, but like all of us, who has that extra 5 minutes to actually go find that thing? Or like for myself, oh man, Diabetes Canada released so many updates to their clinical practice guidelines in 2023, 2024, and 2025. The printed copy definitely sat at the edge of my desk for a while before I get to them because life gets busy. So if there's anything super specific that anyone was hoping to get out of our chat today, I'd love to hear your thoughts. Feel free to pop them in the chat, or if you want to come off mute and just let me know. I'll take a minute just to pause and wait for anyone's suggestions before I jump in. And as stuff comes up, just send your questions on over in the chat. Whenever I do these sessions with patients too, I prod them that my voice isn't that nice to listen to for ever and talking. I want to have a conversation about things. So please keep your questions coming if any come up. But I thought what could maybe spark some creative juices in terms of questions is, what if I presented you with these 4 areas of supporting our patients with prediabetes and diabetes? Screening and diagnosis, definitely. And then we get the whole area of medications, metrics, and measurements and monitoring and self blood glucose monitoring devices, all the things. Before we even get into the dietary and lifestyle and exercise recommendations area, and then all those recommendations on, well, what tests to go for and do and how often. So if these spark anything, let me know. For that first area, screening and diagnosis, we'll jump in there first. But to make sure we don't miss it out, super quick update on some of the things that have come up in the clinical practice guidelines from Diabetes Canada over the last couple of years. Few different areas. Probably the biggest one that stood out recently was that update back in 2024 to the pharmacotherapy chapter of the guidelines, and with the addition of so many new medications in the GLP class and the SGLT2 class, that chapter grew. So much so that they, in fact, created a user guide, which takes providers through some common questions around the therapies, which is best, and new best practices given what we have. There's also been some updates around protecting the kidneys, whole revision of the type 1 chapter, and I'll get to some specifics around there. But, oh, and it's dry in the office. Like I mentioned, I will pop a resource with all these slides in the chat after the meeting today, so you have them all to look back to if you like some more specific details. But when it comes to the medications, the push around our SGLT2 medications and GLP-1 medications like Ozempic, like Jardiance. There's a big focus on leaning into the medications that not only can help people achieve their blood sugar targets, but looking ahead to reduce their cardiovascular risk and keep their kidneys safe. So it's, why not kill two birds with one stone type of therapy approach. And the table, the picture of the flow chart at the bottom of the slide, that's straight from the quick reference guide. And it does a really great job of kind of guiding a provider through, okay, I have a patient, newly diagnosed, what therapy should I consider? It's a great tool in there. The revisions have been awesome in there. So mentioned there was an update around kidneys, kidney health, chronic kidney disease in the guidelines, and they actually added some additional guidelines on additional medications to consider for folks who have CKD or at a high risk for developing complications. They have the renal dosing for medications, several medications to help with blood sugars, can be found in the chart in this picture, again from the quick reference guide. But honestly, nothing specific has changed as far as the cutoffs. There is just a reassurance that all those medications are still effective at lower GFR rates. And again, nothing really has changed in terms of the screening around CKD. It's something that I find that often there's a bit of confusion around, okay, well, if it's recommended to screen folks, sort of where do we start becoming concerned? Because the value in neck care, oh, if the proteins in their urine is less than 3, it's considered normal, although the guidelines suggest monitoring and a follow-up at 2. So that is one thing that I'd like to just highlight quickly. Now, some of those other updates I mentioned, I don't know who encounters a lot of patients with type 1 in their clinics. I know here at Westview, we certainly don't encounter a ton of folks who need support from the nutrition services team in this regard, and it's because those folks often are set up with a specialty clinic that has their whole team to help them with that side of things. But should you ever encounter questions, should you ever want to learn more, Diabetes Canada has an awesome YouTube series called Deep Dives, and there is one posted all about this update to the guidelines around technology to support blood sugar monitoring for folks with type 1. But again, spend a ton of time on. Who has heard about some of the updates around the language change in fatty liver and non-alcoholic fatty liver disease? Now we're talking about metabolically associated steatotic liver disease. A mouthful, MASL, good enough. And also the terms of NASH being switched over to MASH, so metabolic dysfunction associated steatohepatitis, so when inflammation is present. In terms of that screening processes, Diabetes Canada actually added screening for MASH to their recommendations in the past year, and folks with diabetes have an increased risk. And it's thought that as much as 70% of people living with type 2 have MASL. So Diabetes Canada thought that there was a great amount of evidence to suggest to best care for folks with diabetes and catch things sooner. At least every 1 to 2 years, folks are screened with the FIB4 to test for liver fibrosis. Now, there was a bunch of techie stuff. Those are the biggest updates to the guidelines in the last couple of years, and other information is available to you to have a peek through in more detail later. Getting back to our 4 categories here, just the practical day-to-day stuff. Looking at that first area in terms of screening and diagnosis, anyone have any questions about, questions that come up in their daily practice, patient questions around this area, like weird techie bits of detail information that make you go, huh? One thing that comes up in our practice all the time. Well, I'll get there in a second. Another thing that comes up for us all the time is there's very, very high anxiety stress around developing diabetes in folks with a strong family history of diabetes. I have a few patients that their blood sugars are absolutely fine, but unfortunately some other health concerns have come up for them in their life, and they have a strong family history of this condition of type 2 diabetes, so it adds to their general health stress and anxiety. And this is a quote I really like to share with patients in that situation, and it's around studies that have been done in twins. They share genetic material, but we can see in real time how environment and lifestyle affect what conditions we ultimately develop in our life. And although genetics are a part of it, it's how we live our life that matters too. Now, back to that other thing that comes up for me around screening and diagnosis all the time is who's heard their patient say this? Like, Erica's raised her hand. I can raise my hand many times. And this sentence makes for a bit of an awkward trying to suss out, what have you heard? Who said what? What are your numbers? And so, and I saw a question. Hey, Alex, is it a I've heard it or I have a question? You let me know. So I've heard it, yeah, all the time. And I think some of this confusion around I am a borderline diabetic or I have borderline diabetes comes in with this line that is in NetCare and it's in the online charting system. Like when patients get the results in my chart, My Health Alberta, the thing, words. I really feel this line adds so much more confusion than clarity because that is not technically what the guideline says. And not only that, our neighbors to the south have a different cutoff for what is considered an A1C in pre-diabetic range. So it creates a lot of confusion when we're constantly looking at research from research papers and studies and materials from the States and here, and it gets a bit messy. But here in Canada, we classify pre-diabetes between that 6 to 6.4 A1C range, diabetes at 6.5% or higher. And although there is absolutely increased risk at an A1C between 5.6 and 6, as the line in Netcare and in Mitogra suggests, risk might not mean it will happen. It just might indicate that increased screening could be a good idea. So looking at what the guideline suggests around, okay, why did they pick the cutoff? Why is it different from the States? What happened? They talk about, again, while increased risk might exist at this and this and this and this A1C, truly the folks that we really, really need to focus our efforts and energies on prevention and treatment is in prediabetes. That is the highest risk associated with progressing towards diabetes. And when it comes to A1C itself, something that sometimes gets overlooked is, oh, look, is it an accurate measure? Because there's a whole host of stuff that can skew how we ultimately see that result come up. Does this patient just have really old blood cells because they're 95? So many different things affect where we end up landing with our A1C measure. And definitely it's a beautiful standardized test. It is a great marker to go by. Otherwise, guidelines wouldn't suggest we still use it. Sometimes just taking that moment to go, well, this picture of this patient, they are doing well. They're healthy. They're living a healthy lifestyle. They're exercising. They have a family history of diabetes, but their A1C is 5.8. It's kind of been at that place for 5 years. Should this patient be worried? Maybe some additional screening could be a good thing to make sure it stays right at that. But that patient is already doing all the wonderful things we would suggest to them to keep their A1C at 5.8. Now, oh, and one more thing I'll say about A1C, a conversation I have all the time around, oh, but I had a really, I went on a vacation for my week before my blood test, and it must be wrong. A bit of math around A1C. The last 30 days definitely has the biggest impact. So about half of what we see in A1C is the last month. And then if we zoom out, because that red blood cell is living for, much closer to 90 to 120 days. Once we get to the 90 to 120 day mark, yeah, that's about only 10% of the impact. Half of the impact is in the last month, but it's so much more. So I started to put people rest assured that the number was not skewed by the vacation you took last weekend, much broader scale. Now, before we jump into the next section, did that spark any questions for anyone around some nitpicky details when it comes to screening and diagnosis? Feeling okay? Offer stands as we go to the other ones. Don't be shy. In the metrics meds realm, that acronym of the A, B, C, D, E, S, 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 S's of treatment of diabetes. The resource, the picture is clickable to open the resource itself. There are so many great tools that Diabetes Canada has available through their website to help providers navigate all those different sections, including the individualized A1C target calculator. That page also has some, I go there all the time for, I can't quite remember. Okay, does this skew A1C? Does this skew A1C? The calculator page has it right on there. Or, based on this and this and this condition that they have, or yeah, it has all the considerations right in one place. So I love it for that. And And yeah, the link is clickable. Prescription tools, again, like they have so many great printable PDFs, like quick reference tools for the office to help around, okay, which patient is it again that will benefit from an added statin, or who should I consider for blood pressure medications and which ones? And how often should I be checking blood pressure for this patient, or what's targets? The prescription tools are updated even with some of the newer products like the weekly insulin, all of the new GLP-1 therapies, they're all there. The renal dosing chart is another great one. And the insulin prescription tool, again, the back of them have the science and data and details and links. So if ever you're like, well, what was that recommendation again, or where did it come from? They're all in the tool. So I really like them as references. Something I hear quite often, something that comes up around when we see patients in the nutrition services practice around meds, is this idea that it's my fault, I failed because I need diabetes medication, or it's my fault, I failed, now I need insulin. And I would take a moment to speak to that view or that mindset, just because it hurts my heart when anyone feels like, oh, this is something I did wrong, this is a failure. And it's so not the case, as we all know. But so often I know that it's crazy in the practice, it's busy, there's 1,000 things going on. But I think taking a moment to speak to patients about that view or that belief can help them set up for success in treating a progressive condition like diabetes, where, through no fault of someone's own, as a condition like that progresses, sometimes they may need insulin and it's completely not their fault. So comparison that I heard eons and eons ago when I got to be an intern, a beautiful and brilliant nurse practitioner said to a patient who was beating this about needing a medication to correct their diabetes. In fact, they were newly diagnosed and needed insulin right away to just bring those levels down and help them manage quicker. Is she told them, well, I see you wear glasses. If your optometrist said, oh, your life will be a lot better if you wear glasses, is that your fault? And the patient said, well, no. And she said, well, same thing. Your body said, you know what? We're not working the same as we used to. Sorry. And sometimes we need glasses. So that always stuck with me. And I thought, yeah, okay. I love that. It's mine now. I'm going to use it forever. And again, yeah, clickable links in there. Another thing around meds that I hear all the time is, oh, well, I'm having an awful day. I had the stomach flu. I'm going for a scope. Should I still take my diabetes medications? And Diabetes Canada has a great resource for just this purpose. It is a checklist. It has a space to write in the patient's own medications. And it's that SAD-MENS acronym of which medications to ideally suggest the patient stops or holds in cases where they're not going to eat. They might become volume depleted. Dehydration is a risk. They're not really eating. So I find that is a great tool to direct patients to in that situation. I usually send them to chat with their pharmacist if their doctor's not accessible too, because as a CDE role, yeah, I can talk about that, but my main role is a dietitian too. So it's a bit tricky around prescriptions and patients there. It's much more appropriate for their physician or prescribing pharmacist to have those conversations with them. So any questions around the medications, around which to hold and which to continue? I said, great tool. Love it. Refer to it all the time. Another thing that comes up in our practice all the time when we see patients is questions around, well, should I be monitoring? Should I be checking? Should I be finger poking? Is an A1C okay? Should I buy a Libre and check all the time? Have you guys found the same? Like, is there a range of different, like, when should we check? Again, there's a tool for that. I feel like I'm gonna say it 1,000 times today, but there is a interactive version of this tool and there is a printable PDF version of this tool, and links right in there too. It walks through different situations in terms of each patient and what might be going on for them, and makes a recommendation around how often they should consider checking. One area that I often find that I spend a lot of time talking about is folks who have normal blood sugars or folks with prediabetes, and they went out and they bought a Libre and they stuck it on. They were really worried about what they saw. And then also they started treating low blood sugars that were not truly lows. And we get into a whole cycle. In prediabetes, it is actually recommended to not monitor because weird things will come up. Some people walk around at a blood sugar of 3.7 and they feel wholeheartedly fine. But yet the Libra says, oh no, you're low. And now people get stressed out and snack, and then they go higher, and it's a bit of chaos. So another part I always find really reassuring, what I find helpful for people to reassure them is they are on a stable dose of medications that don't really have a high hyperglycemic risk. They need to finger poke if they've had diabetes for a long time and they're very familiar and very comfortable. Save their fingers. Or if they're on basal insulin, the doses are completely stable, their A1C is a target, things are just, they're stable. Spot checking is totally fine. Now, the backside of that resource has this crazy looking table, but it's actually quite neat. And the reason why I like it is it gives some reminders or suggestions or tips around if someone is on a long-acting insulin and a mealtime insulin or a rapid insulin, how to help them adjust it. So the back of the sheet is a whole bunch of info, but yeah, if anyone needs a quick reference and pointers on helping someone adjust their basal and bolus insulin, it's a lovely table. They did a great job at it. The link is in there. With the rise of Freestyle, Dexcom, all those continuous glucose monitors, Diabetes Canada added a table to their quick reference guide for what we should suggest targets to be. So no longer can we say like, oh yeah, just this and this before meals and this in the morning. That's all good and well, but we have so much more data that is linked to someone who might be monitoring continuously. And a really neat metric that I've come across and I do tend to talk to my patients about is small changes, big impact. If they look at a month's blood sugar reports and their time in range, so the time spent between 3.9 and 10, it was 65%. If we can get it to 75%, and of course there's the sustained piece, it's a really significant impact to their A1C. In fact, as much as adding some medications do is that amount of change in A1C. So small changes, big impact. I also get a lot of questions around coverage when it comes to the Freestyle, the Dexcom. That link will take you to the Alberta Drug Benefit List as of December last year already. Wow, time has flown. They have added a bunch of new programs that are eligible for coverage as a restricted benefit, but Alberta Seniors, Alberta Child Health Benefit, AISH, Alberta Works, like all of the group programs have can be eligible for continuous glucose monitor sensor coverage if they are an adult and on insulin that is long acting and rapid acting, or insulin pump. So they have to be on both in basal bolus therapy or long and short acting insulin or an insulin pump. And if they're under 18 and get coverage through one of those programs, they just have to be on insulin, period. And they are eligible for coverage or pump therapy. So a lot of folks are newly, well, for the past year, but a lot of folks are now eligible for coverage that were not before. I have had a lot of success with helping some of my senior patients learn more about their blood sugars now that they could have access to coverage for a sensor, and seen some really, really neat things. And yeah, just buying into their own care. When else can we see in real time how our lifestyle choices affect our body on the inside? So I've had some really, really good success with that. Hypoglycemia and keeping patients safe from hypoglycemia was a bit of an older update to the guidelines in 2023. But again, I thought I would just pop this one in there. Something that comes up for Erika in our practice, not all the time, I'd say, but often, is a concern around treating low blood sugars that are not typically a concern. So if someone absolutely is on a medication that affects insulin secretion or insulin itself, yeah, we want to treat if blood sugars get 4 and lower. Also, if someone is feeling unwell, so perhaps just symptomatic hypoglycemia, their blood sugar might not be low. It's worthwhile treating. But let's say someone randomly checked their blood sugar and they're not on an insulin secreting medication, they're not on insulin itself, they felt fine. It's just a case of maybe they randomly started wearing a glucose monitor, or they poked, or what have you. And all of a sudden, they see a 3.8. Should they treat? And spend a lot of time reassuring people that no, it is not necessary to go and add a snack and treat it like a low blood sugar. If you felt fine and you're not on these medications and you would have never known, truly, no need to treat. Because technically a random blood sugar, that range goes all the way down to 3.3. Is still considered normal. And some people just run low. Unless we're going to manipulate their inner biochemistry by putting them on medications and insulin. Yeah, then we've messed with the normal system. Then we got to treat. And that's just the back of that handout in terms of treatment options. I think who's had the patient who treats their low blood sugar with a brownie or a cinnamon bun or slabs of chocolate, or all the delicious, wonderful things that, yes, now I just get to have this because I'm treating my low blood sugar. I would have to say, yeah, have those things. Treats are wonderful. Treats are part of healthy eating. But I always take a moment to educate them around, well, okay, so there's the sugar, but what else comes in those treats? It's a lot of fat. How long might it take your body to get to the sugar in that chocolate if we're slowing it down with fat and protein that needs to be digested too? It's truly a low, we want quick. So yeah, let's just take a minute to check in with folks about what they actually use to treat lows as well. Now, in the interest of not making us late, I'll go a bit quicker through the next section because truly it is what we love to support you with. It's all the lifestyle pieces around food and healthy eating. Diabetes Canada has a fabulous resource that is a really great overview of all of the main topics around food and blood sugars. One of the key tools that they teach in there is our good old balanced plate. And my not funny, I think is funny and very entertaining joke around the balanced plate is I teach it to my patients who are in kindergarten, and I try to convince adults that it never had to get more complicated. Like the balanced plate method is truly the one-stop approach to whatever your goal is. Are you trying to eat in a way to support meeting your nutrient needs? Hey, try to make a balanced plate at meals. Are you trying to support healthy blood sugars? Hey, a balanced plate. Are you trying to eat an anti-inflammatory diet? You would have never guessed. It's the balanced plate. Whatever their goal is, heart health, digestive health, you name it. Just keeping this graphic in mind when putting foods together at a meal and the proportions gets you so far without anything else. The handout also talks about the handy portion guide, which can be handy as a starting point. I always tell folks, start there. If you need more, and that's okay. But yeah, the Diabetes Canada resource is great for all of the highlights when it comes to, well, what do I do in terms of food to help manage my blood sugars? And it's the same in diabetes, pre-diabetes, does not even change. Now, there are some hot topics that come up all the time around intermittent fasting and ketogenic diets. And so much so that Diabetes Canada actually made handouts on them and position paper statements on them. The quick version of how I usually answer patients' questions around them is that a way that would truly fit with your best lifestyle for forever? The answer I usually get is no, but sometimes I get a yes. And then my second question would be, well, eating this way, could you see any concerns with missing out on some nutrients? When we have the keto discussion, fiber is usually pretty quick to come up. Or intermittent fasting is, oh, well, I get really cranky when I'm hungry, or, ooh, I find that I eat twice as much later in the day, or so a little bit of just helping themselves find their own answer about, this is how I want to eat forever. Could I still meet my nutrient needs? Would I still be a happy human? And those resources help with some more guidance and tips. The recommendations ultimately for both of those dietary patterns, there is no evidence to support any superiority over eating regularly through the day in a way that we've taught forever. Until we find some more really stellar evidence. I'm always open to change, but I'll take the ballast plate for now. Ultimately, though, there are still some patients who are like, but what is the best diet? They want a diet. They want a page. They want a label. They want a thing. No matter how many of my guiding, leading, coddling questions I ask. And for those patients, I go, here we go. Here's the Mediterranean diet. It has the word diet in it. And then we talk about all the great benefits for blood sugars. We talk about all the great cardiovascular benefits, anti-inflammatory benefits, you name it, diet. There's a diet for them. If your patient wants some more stuff until they get to maybe meet with a dietitian, with us, with a different team, Diabetes Canada has awesome YouTube video series that talk about all of those food topics. They talk about the hot topics are like the keto diet, the intermittent fasting. They talk about money saving tips. There's also an entire video series on cooking and recipes for two. And so they're cute and they're lovely. They're all accessible through the links that are just in the PowerPoint. So no worries about accessing them later. For patients whose first language is not English, Diabetes Canada has also put the Getting Started with Healthy Eating for Diabetes handout. They've also translated it into many other different languages and created videos that talk through all of the key elements of that resource. So if you have anyone like that come across your practice, it can be a great tool as well. And then just shameless for the Nutrition Services Program. We have a whole bunch of different classes here at the PCN. No referral needed. Patients can literally just call us up or go to the website. The QR code will take you straight to the page where there's more information on our classes as well. They are free to attend. We keep the cycle going every 3 months. We do in-person, we do virtual, we do mornings, there's options. So if they'd like to attend one of our nutrition services group classes, they it's an entirely self-directed option for them that they can access to. Now, physical activity, of course, there's a handout for that. But similarly to the nutrition topics, there is also videos that Diabetes Canada did on tips and tricks to get folks started if they're not quite sure what resistance exercises mean or what cardiovascular fitness is, or just basic tips on how to do exercises at home. Those are pretty great videos and resources for them. And that takes us to that last section, which is so much numbers and metrics and stuff to keep in mind whenever I think about the monitoring section and the recommendations. I see this dashboard in my head of dials and knobs and like fluid levels, and it almost feels like a control panel of an intricate machine that is just trying to keep track of labs and tests and markers. Different EMRs have different functionalities and capabilities to help users keep track of all those different tests and parameters. So have a look at yours if there is maybe even built in ways that can make keeping track of all those tests for your patients with diabetes or prediabetes a bit easier. Yeah, that can be a great thing. The main new addition there I've pointed out is that suggestion around sending patients for FIB4 for their liver health screening every 1 to 2 years, and the rest pretty stable for a few years. One new tool to help providers out and keeping track of, oh, I changed the order on myself. I was a PDF tool is, keeping all the metrics and follow-up tests and labs and measurements straight. Diabetes kind of have a great patient tool that talks about screening and monitoring and how often, and it's a checklist format. So that's a really neat way to keep track of it too. But the newest addition to the monitoring toolkit around immunizations is, I think in the last few months has been added, but it summarizes all of the recommendations on all the different immunizations and more information on each one of them on the back of the tool as well. Lastly, because who has time to go download all the PDFs, I made sure to create a shared Google Drive that has a copy of all the different tools I mentioned today in their PDF form. They're through the QR code on the left. And if you needed some nutrition resources, not only from Diabetes Canada and not only for diabetes, the QR code on the right will take you to our shared nutrition information and resources folder. Feel free to use it, download, save, go for gold. Erica and I use the resources in there all the time in our practice, and it's ones that we, as we find new ones, we add and change all the time, but it's ones that we would share with patients. So feel free to use anyone in your practice. Now, that does take us to the end. I'm so sorry if I left very, very little time, Christina. My apologies. I just want to quickly put it out there. Any questions? Obi?
Everybody's so quiet today. No questions, hey? No questions from Connect Care. Thank you so much for all the awesome resources. Yes, thank you, Connect Care. Anybody else? I just wanted to share a little tip that we're fortunate enough at Westview PCN to work with Mariska and Erica from the nutrition services team, and we did an event, and one of the patients from Paul First Nation came up to our lovely dietitians and said, I just don't like vegetables. And the comment that they said back was, I think you just haven't found the way you like to eat vegetables or the vegetables that you enjoy eating. So I thought that was a really great thing that, as Mariska said, I'm gonna take this tip that the NP said to me, and use that as my own. That's one that I have kind of adopted from them. If I was doing patient care again, I think that's a really relevant way to encourage, healthy eating and fiber and all those good things that Mariska and Erica teach us about. And I think it's really good that we're sharing those resources. So thank you for that. I think that's an excellent thing for the clinics to have access to, because oftentimes the physicians, like you said, don't have time to, provide those resources, and then they get sent to you and then might have a waiting period. So it's a nice little gap that we can fill with those resources. So that's awesome. Thank you very much for that. Mhm. Um, Amanda, if we want to just go ahead with the quality improvement slide. So we just wanted to share a little bit of what the quality improvement team is working on. So our next meeting, we're going to discuss some more shadow billing, because of course that's been a big chunk of our time lately. We've had lots of conversations about that in working group meetings. So some of you have been a part of that, and we appreciate everybody's input there, as Amanda said earlier. I personally have had a lot of questions for some nursing skills to be updated from physicians, from nurses, from clinical staff. So I have a small list started, and I'm going to be working in the new year with probably our medical director and maybe nurse practitioner to do some skills refreshers. So if there's anything that you guys can think of, the ones on the call that are nurses, any skills or anything that you haven't done in a while that you think would be good to update or refresh, or something that you have an interest in learning, reach out to me and let me know. You can email, text, call, whatever works for you. I have a small list started, but maybe there's some things that I haven't thought of. The other thing that we're doing is I have officially been designated by Nikki to be our fit mask testing designate. So I'm certified to test everybody and fit them for their N95 masks. So we'll be setting aside some time or coming up with some dates. I think the best option might be to have the sessions at the PCN office, but we can certainly discuss what might work best for clinics if they want me to come there and certify, test to fit a bunch of people at once, and that captures more of the staff, then that's a possibility as well. So I think that everybody's certification should be expiring according to Westview PCN records in February. So we're going to try to get some of those sessions up in the new year. And I think that's it. Does anybody have any questions about any of those updates? Everybody's so quiet today. All right. So I will take that as a no. And look at that, Mariska. We have 5 minutes left. So the next clinical associate meeting is on March 18th from 1 to 2. So same day, same time. Probably doing the virtual option again is the plan. And that too, if anybody has any input on virtual, hybrid, in person. We've been holding some meetings in person, which has given us a lot of valuable conversations with clinics. And it's nice to kind of get everybody together in the same room, especially, peers that you don't get to see very often in other clinics and things that are going on there. So it's nice to kind of talk to other staff sometimes, and not always through me or whoever's doing clinic visits. So something to consider going forward, whether we continue with virtual or hybrid or combination of both or in person. So I think that is it today, if nobody has anything else. I want to say thanks again to Mariska. It was an amazing presentation. I know I learned a few things because I haven't been working with patients for the last year. So it was a really good update of everything. Yeah. Exactly. Thank you, Melissa. It was a really good presentation with loads of information. So really appreciate all your work on that, Mariska. All right. Everybody stay warm, drive safe, and we'll see you, I guess, in March or sooner if I see you in clinic. Thanks, everyone.